we're going to go over Unit 2A, which encompasses pretty much Chapter 16 in your Louder Milk e-book. So first we got to talk about the 5 factors associated with labor. These are also the 5 P's. These include the passenger, the passageway, the position, the powers, and the psychological response. Now, the passenger, you're going to have to remember, encompasses both the fetus and the placenta. All right, we've got 2 major organ systems that must be evacuated during the laboring process. The passageway refers to that birth canal. The position of the fetus, we'll also be talking about. The powers include the contractions, which would be not only the part where mom is feeling the involuntary contractions that are occurring within the smooth muscle of the uterus, but also the mother bearing down as well and aiding into that. The psychological response also plays an important part in the laboring process, but is not one that we will specifically focus a ton on. So when we're talking about, first of all, the passenger, let's focus on primarily the fetus. We're going to look at the way that the passenger moves through the birth canal. And there are a couple of different factors that are part of why or how that fetus does that. So we're going to talk about the presentation, the lie, the attitude, and the position in just a moment. But the first thing that we're going to talk about is the fetal head and how that impacts the laboring process. So the fetal head has a very significant impact, obviously, upon the laboring process. If you can try to imagine, and we'll talk about it here in a bit, a fetal head that is too large for a birth canal is simply not going to be able to move through and go down the passageway. That would obviously hinder the laboring process and cause a problem. So the head is the largest, it is the widest, and it is the most rigid of all of the fetal structures as it tries to make its way through the birth canal. The bones have not been fused together as of yet. We have the sutures, which if you're looking here, you can see we've got the sagittal suture, which is between the posterior and the anterior fontanelles. We have the lambdoid suture and as well the coronal suture. These are soft membranes. So you'll hear people talk about the soft spots. That's actually these fontanelles, but the sutures are intersecting these, and you can actually feel those on a newborn infant. You can feel whether those are open, which sometimes, eventually they will spread out and open, or you might see it with a C-section delivery as well. Or those suture lines might be overlapping, and they would overlap during the vaginal birthing process as the head is squeezed through the passageway. However, these soft membranes then, like I said, they can overlap. They can allow the overlapping of some of these bones, which really allows some flexibility, some pliability, but then during the birthing process, but then also for that exponential brain growth that's really going to happen within the next year of life, next year or two, okay? So after the membranes have been ruptured and a provider or a nurse goes ahead and assesses the fetus, if we have, which we want to have, a fetus that is pointing head first through the passageway, we're going to be able to feel those suture lines in those fontanelles. And because of the size of those fontanelles and what we expect the gestational age of the baby to be, we're going to be able to determine those other factors, the presentation, the position, and the attitude of the infant. As I mentioned prior, you can have those overlapping sutures. You can have some where those suture lines, and then you can also have a really odd shaping of the head, which we'll talk about here in a little bit as well. And this molding is what it's called. It can occur at birth, like I mentioned, because of the overlapping bones, but also because of fluid accumulation. Anytime where you have any kind of trauma, right, you're going to typically see an inflammatory process. You're going to see that fluid. Well, the fetal head has gone through a traumatic situation. You're going to see a little bit of fluid accumulation potentially following a vaginal delivery. Again, that molding and that shaping reverts back to normal within a very short time. But again, it's something that is allowed to happen because of the head. The anterior fontanelle, so you will need to know this, the anterior fontanelle is the junction of the sagittal, coronal, and frontal sutures. Okay, you're going to have to obviously be able to palpate that on an infant during your physical examination. This is a diamond shape, and this will close at around 12 to 18 months, okay, of age. The posterior fontanelle, literally, on my fake baby, all right, and we'll look at this closer in class as well, you have a very large triangle here. It's very, very exaggerated. In reality, it's literally like a fingertip, okay, that you're able to put on, that you're able to feel. That is the junction of the posterior, the two parietal bones and the occipital bone. And this one obviously is going to close a lot faster, you guys. This one's going to close rather quickly, within less than 2 months after delivery. We also have special names just to make things more difficult when we're talking about the fetal head. Not really. It's going to help us later on when we're talking about which part of the presentation, okay, happens. So we name our passengers skull bones in this way. The frontal bone becomes the sinciput. The vertex is the area between the anterior and posterior fontanelle. If you are delivering a baby, you want the vertex. You do not want the sinciput, and you definitely do not want the mentum, okay? The occiput as well is, you want them to be in one of these two vertex or occiput positions, okay? And this helps us when we're discussing, like I said, the way that the baby is coming out. And as you'll see when we move a little further on, it really depends on where this mentum is, where that chin has been tucked down. So when we're looking at the different types of presentations, this is a vertex position that you're seeing in this picture here, between the mother's two legs, between her hips. You're able to see, what I like about this picture is that you're able to see how once that membrane and that head, the membranes have been ruptured and the head starts to come through the vaginal opening, how you can see these, the fontanelles. And that obviously is going to help, like I said, the provider determine. So there are three main types. We can have a breech presentation, a shoulder presentation, or a cephalic presentation, which is called vertex. Cephalic head, vertex, remember that vertex is that space between those two fontanelles, and that's where we want to go. When we're talking about those presentations, cephalic is going to be about 96% of all deliveries. Breech is going to be about 3%, and that's the buttocks first, and the shoulder is actually 1%. Usually those babies flip. I just want to go back here really quick. I just want to make sure that we understand this part, okay? So we need to clarify, there are 3 presentations, but we also have 3 presenting parts, okay? So you can have a cephalic, and then we're going to talk about the crown of the head. The breech, Okay, we're talking about not only the way the baby enters the birth canal first, but then also the part that comes, that we're able to feel during that internal exam. When we're talking about breech presentation, it doesn't just stop with, hey, we've got breech. There are 3 different types of breech presentation. Our frank position, which is in the middle, this baby potentially can be delivered vaginally. In a frank breech position, the buttocks are first into the pelvic inlet, okay? Both legs are extended completely upward against the face. The hips are flexed and the knees are completely extended. In figure B, this baby has now made its whole presenting part wider and more difficult to be delivered. When the hips and the knees are both flexed, we still have buttocks first, but this presenting part now becomes this much larger to go through the vaginal canal than the head. This is definitely going to be a C-section delivery. Then we have a footling delivery over here, your figure C. Footling delivery can refer to either one or both of the feet that present out of the pelvic inlet. The problem with these, and this is also going to be a C-section delivery, the problem with each of these each of these breech deliveries, potentially with the frank, you can get some dilation, but dilation is actually the force that's placed upon the cervix to encourage it to widen. Well, you need something hard against that cervix in order for it to do that normal dilation process. We have soft butt versus a firm head. The firm head is much more efficient at doing that cervical dilation than the soft butt will do. There's also very concerned, if you're looking at figure C right now, if we end up with one or both of those feet through, you think, oh, well, that head is just going to follow those legs. Not necessarily. We're going to talk about, in week 3 of our clinical, the cardinal movements of labor. And the head and the body actually follow a very specific pattern as they twist through the birth canal for a successful vaginal delivery. And the head can get caught at any moment in those points, as in those twists and those turns, causing trauma. And that's exactly what could happen again with this footling delivery, is we immediately evacuate the foot, the feet, the hips. We've got a chance now for the shoulder to get caught. We also have a huge possibility of causing some head trauma. After a breech delivery, if we've had a successful vaginal breech delivery, the nurse's responsibility on the postpartum unit is to really observe that infant for leg movements, for kind of those hip movements. We're going to be concerned about the possibility that we have done some trauma to that as well. We will also, I'm just going to mention the shoulder. The shoulder presentation becomes what we call a transverse lie, which again we'll get into here momentarily, but that requires a C-section. So longitudinal, which will include your vertical, your longitudinal lie, you're going to have breech and your vertex deliveries, right, in this, either way. They're going to be, their spine is going to be parallel to their mothers. Whereas a transverse, we're going to have that shoulder presentation, and in this case, we're going to have their spine is perpendicular to their mothers. Okay. This is highly uncommon. It usually will rotate one or the other. Okay. So as I mentioned, it is so key during those cardinal movements of labor for the head to twist and turn through the birth canal so as to have a successful delivery which causes the least amount of trauma to mom and to fetus. So one of the things that we talk about is their attitude. Okay, and all I can think of is Gru from the Minions or whatever is like attitude, and gets that little head wagging into it. So that's what I think of when I hear attitude. But this is really referring to the relationship of fetal parts to one another. And so for some babies, it is literally how they form within the womb, and how the way that the fetus conforms to the shape of the uterine cavity. Other times it's just, like I said, in relation to the fetus's growth. So we have these, like I said, we have three main attitudes. We have, and again, I want you to think about these presentations right here. We've got vertex, sinciput, and brow presentation. Okay, when we're talking about these are all, the three presenting parts here are all going to be cephalic in this case, all right? So let me go back here really quick. Okay, so remember, these are our parts. Sinciput, remember, this is the part of our brow here, or our frontal bones. The vertex, the mentum, the occiput. Okay? And those three presentations were breech, shoulder, or cephalic. Now let's talk about further here within the attitude. Our presenting part is still going to be cephalic. Okay? But we're going to have a vertex presentation, a sinciput presentation, and a brow presentation when we're talking about the attitude. So, first we have a general or complete. Okay? So in this case, this is the fetal position, this vertex position A, and this is the one you want. If you're going to have a vaginal delivery, this is the part where you want your baby to be at. Okay? What we're looking at here is the suboccipital brachmatic diameter. So over here on the left, we're going to look at the shape or the size of that fetal skull. And the suboccipital brachmatic diameter is 9.5 centimeters. So if that part, which refers to the vertex position, enters the pelvic inlet first, we are successful because we have a pelvic inlet of about 9.5 centimeters, which would allow for a successful delivery. In this case, the infant, the fetus's chin is fully touching the sternum. See how the chin fully rests on the chest of the baby? That needs to happen in order for this vertex presentation to occur. In this case as well, when you think of that fetal position, the spine and the back are going to be rounded. The arms are going to be folded into the chest. The umbilical cord is safely between the arms and the legs of the fetus. The thighs are flexed on the abdomen as well. The knees are flexed. And again, it allows for this suboccipital brachmatic diameter, this biparietal diameter, the smallest one possible to fit into that pelvic inlet. Okay. Now, when you're looking at that diameter right here, that is the widest part of the head. Now we move that chin up into this sinciput presentation. Did the infant's head change diameter? Absolutely not. What did change is the angle that the head is coming into the pelvic inlet, and then that changes the diameter significantly of what needs to happen through the pelvic inlet. When we're in a sinciput presentation, we have an occipital frontal diameter that needs to move through. This is also called the military attitude because this baby is kind of looking straight on, like they're at attention. And then brow presentation, the presenting part, in this case, is going to be the mentum. This is what's coming through the head first, or excuse me, coming through the vaginal canal first. So it's a brow presentation with a mentum presenting part. This is the widest. This is going to be the occipital mental biparietal diameter at 13.5 centimeters. That mother's pelvic inlet is going to have to be 13.5 centimeters in order for her to successfully deliver that infant without any help, without any trauma to mom and to baby. And to be honest, you guys, that is a very, very rare occurrence. In this case, when we're talking about trauma, the bruising and the petechiae on the forehead will be present from, this is like going to be a failed vaginal delivery. So the head is going to be bouncing against this pelvic inlet as the mother tries to push, as we have those involuntary contractions. As all of that is happening, like I said, you've got this right here on the forehead and in the eyes. We're going to have those petechiae from that happening. So not a good thing. We'll probably end up doing a C-section. Alright, so when we're talking about position, we take all of these factors and we put them into abbreviations. So we're looking at the position of the baby, and all of this goes into the provider's charting. If you open up the delivery report, you're going to be able to see all of that because it all plays a significant part in how well the delivery and the birth go. So we're talking about how the fetus's presenting part is, and when we're looking at like a pretend map of the mother's pelvis, and kind of determining how that relates to a specific part on her pelvis. Okay? When we're talking about presentation, we're talking about a presenting part to the pelvic inlet. This is a specific part of the pelvis. So just kind of differentiate between the two of those there. Okay? So the first letter defines whether the landmark is left or right. The second landmark talks about the fetal landmark, whether we're doing occiput, mentum, sacrum, scapula, or the third letter then defines whether the landmark points anterior, posteriorly, or transverse. So in this case, if you take a time to go ahead and look at this, we're going to be looking at a baby that comes out LOA, ROA. LOA or ROA, that's going to be the way that you want your baby to come out if you're, again, having a vaginal delivery, because this is the widest part of your pelvis that baby is going to go into. The right occipital posterior and the left occipital posterior, if the baby decides to enter the pelvic inlet in that way, and the provider assesses that the position of the baby is ROP, okay, now this part of the pelvis down by where the pubic symphysis is a little bit more narrow, and that may make things a little bit more difficult. Okay. And again, when we're looking at the transverse, if this baby is pointing transverse, not the presenting part, but the position is pointing transverse, again, this is going to be more narrow, and mom is going to have a little bit more difficulty passing that baby vaginally. Station is going to be a huge concept for you to understand. Expect multiple test questions and NCLEX test questions about station. So station is talking about the relationship of the presenting part to the level of the mother's ischial spines. Where are her ischial spines? Okay, there's going to be this third bump here, right at this 0. So is mom, really, we've got wide spots here for baby to float around in, but once baby hits the ischial spines, baby is fully what we call engaged. Why do we care about this? Well, when we are able to measure station, we are doing a measurement of what we're measuring really is the rate of descent. We don't want a delivery that goes too quickly, which again has high risk of trauma, or too slowly. If we have a baby that's stuck within the birth canal and not moving or continuing to progress, like this baby would be difficult because it's a transverse lie, for example. We might be concerned that labor is stalled, that there's some sort of issue, and that perhaps we need to move to a C-section. So when we're talking about 0, we're talking about when the presenting part is at the level of those ischial spines. When we're talking about a negative station, we're talking about the presenting part is above those ischial spines. These are measured in centimeter markings, so -1, -2, etc. Positive station, when the presenting part is below the level of those ischial spines. So again, on the diagram, you see 0 followed by +1, +2, +3, +4. At +4 or +5, birth is like happening. This head is right down here. It's happening. It's imminent. When we talk about engagement, and engagement is a term that is related to station and is also very important. So this is referring to the largest diameter of the presenting part. So obviously we want a cephalic delivery, we want a vertex delivery, we want that head facing downward into that pelvic inlet. Okay, so this is usually the biparietal diameter that we're referring to, has passed through the pelvic inlet and is into the true pelvis. It corresponds to station 0. In first-time moms or nulliparas, it occurs in the weeks before labor. And in multiparas, we may not actually get to have that happen until we're actively right before labor or in active labor. So engagement, what you want to think about it is the baby's head, all right, and we're putting an engagement ring on it, okay? An engagement, this is also key because if it's the largest part of the baby, then nothing else can escape through on the other sides. And by anything else, we're referring specifically to the umbilical cord. So obviously, if this is a premature rupture of membranes, a PROM, or a spontaneous rupture of membranes, SRM, okay, if those waters have broken before or without any assistance from the medical staff, then we don't have any control over whether or not that umbilical cord slips down. Okay, but if we're going to augment that labor, if we're going to do that artificial rupture of membranes, we must wait until that head is engaged before we are able to rupture those membranes. It's a safety issue. You absolutely do not want that cord caught in between. So Leopold's maneuvers are a non-invasive way to measure, or not to measure, excuse me, but to assess and determine that fetal presentation. It's a systematic way, the provider has, as you can see, a precise set of movements, the first maneuver, second maneuver, third maneuver, fourth maneuver, and that they palpate the uterus through the abdomen, and again, they're looking at that lie and that presentation. Used more so by the midwives, the providers tend to use more of the ultrasound to help determine all of that. So we talked about the passenger, right? And all of the factors that are related to our passenger, and how they have to lay, and their attitude, and their presenting part, and all of those very important factors. But you can have the best head, you can have a baby enter the pelvic inlet at the exact correct, diameter, and all of that be wonderful, but if you have the wrong shaped pelvis, you're still not going to have a successful vaginal delivery. So this is why we have to take into account all of these different factors when we're discussing the laboring process. So the passageway refers obviously to the route that the fetus must travel. It consists of the maternal pelvis and also the soft tissues of the cervix, excuse me. So when we are pregnant, we have these hormones called relaxin, which is also part of estrogen. And these cause the connective tissues of the pelvic floor and the vagina to become more relaxed and elastic. But that doesn't mean like you're all topsy-turvy with your pelvis, okay? Because no pregnant woman could be able to walk. I mean, it's difficult enough as it is. For anybody who has been pregnant, they will be able to tell you those last couple of weeks, nobody wants to do much of anything, okay? But it's not like your whole body just falls apart because you've got so much relaxin and estrogen pumping through your body. But it does allow for some stretching to occur, but yet it's not going to just magically change the shape of your pelvis. The infant is still going to have to fit through a bony structure. So we have, when we're talking about the pelvis, we're talking about a couple different parts. We've got the false pelvis, which are those upper parts of the pelvis, okay? It's the flared parts. It's what you can feel in your hip bones, all right? Do I care that the head can fit through there? Heck no. I mean, that's wide on everybody, right? We've got a nice wide diameter there. That's not really what I care about. I care about the head being able to fit through the true pelvis, okay? So when we're talking about different types of pelvi, we have 4. We have gynecoid, android, anthropoid, and platyploid. So the gynecoid is the classic female-shaped pelvis. This is how they can tell on those mummies whether we're looking at male or female. One way is by looking at the pelvis, all right? So this is half of all those pelvi around the world. It's kind of ovoid or kind of round in shape. When you're looking at the hearts there, the red, you can see how it's has more of that ovoid shape to it. Again, you don't want a very narrow or shortened true pelvis because it needs to get that biparietal diameter through. The android resembles kind of more of that male pelvis. About 20% of all women that are walking around have a pelvis that can be classified more towards that android. It's funnel shaped. This is a really true kind of heart shape inside of that pelvis. It is not really favorable for a vaginal delivery. Anthropoid is more oval and more wide, and this one can actually be favorable for vaginal delivery as well. That baby is just going to have to turn a little bit differently. We might have to assist that baby kind of to help baby move into a better position with this pelvis, but this one can be successful for a vaginal delivery. In this case, the sacrum is long in this pelvis, but again, and also when you're looking at, look at those mid-pelvis pictures and the outlet pictures as well, when you're talking about how much space a baby has in order to rotate and get their head through. Platyploid is what we call a very flat pelvis. When you're looking at that mid-pelvis picture, when you're kind of looking at that in that box, the top left picture, you have it looks like a squat pelvis, right? Especially as compared to that android pelvis. And so when you have this very squat pelvis, the pelvic inlets, those are kind of down lower. It's really not favorable as when you're looking at the mid-pelvis, the next lower picture, when we're looking back at that sacrum, that head is going to have to emerge transverse. It's going to be a little bit more difficult for mom to push through. So do we all fall into one of these 4 categories, like cut and dry, that's it? No. I mean, everybody's, a mix of one of these 4 usually. So it's really hard to walk in and say, hey, you have an android pelvis and are not going to be successful in this delivery. So that's that. okay? And then we don't really do that. All right, next we're going to talk about powers, or those uterine contractions. So the soft tissues of the lower uterine segment, which is the cervix, okay, the pelvic floor muscles, the vagina, and the intraosseous, or the vaginal opening, are all involved in the uterine contraction process. During effacement, I'm just going to skip ahead to the next slide here for a moment. What we're looking at is this cervix as it pulls up to the sides, okay? It doesn't, when we talk about a thinning cervix, we're talking about when it kind of pulls, like I said, it pulls up towards the sides. It doesn't actually go anywhere. It's not like it's like falling out or anything like that, but it slides up the sides of that uterus. Go back here. So we want to have that moving up towards the uterus in order for the lower uterine segment to gradually distend. So during labor, what we really want is a uterine body where we have a thick, muscular upper portion and a really passive, thin lower segment. The primary power when we're talking about laboring contractions is the involuntary muscle contractions, uterine contractions. So that myometrium is like going to town. The secondary powers are the voluntary bearing down efforts of mom in the second stage of labor. So this is when we're giving mom the directive to push, and she actually does that, okay? So contractions, when we're talking about these as well, when we're talking about the involuntary part of a contraction, we talk about there is a relaxation period during these contractions in which the blood is allowed to flow to the uterus and to the placenta. When you think of a muscle contraction or anything like that, you think of all of those muscle fibers just squeezing, right, and pulling and tightening, whichever way that they have to in order to achieve the desired action. When that happens, if you stay in that position for too long, what begins to happen? You begin to have that buildup of lactic acid, the breakdown of muscle fibers, etc. So you need a relaxation period in order to allow for perfusion to occur. The upper portion of the contraction, during the contraction, the upper portion of that uterus, as I mentioned, becomes shorter and thicker. This allows, the top part of the uterus is called the fundus. Okay, remember that? I think you've heard that term before. Okay, so the idea is that the contraction actually starts at the top of the uterus, there at that fundus, super muscular, and it's going to push that contraction down the uterus through that passive lower segment, okay? And it's going to do that in kind of that wave formation, which laboring women can kind of relate to. And again, this lower uterus becomes longer and thinner during this process. Okay? The other portion that we need to talk about, this physiological ring that separates the upper and the lower uterine segment, is called the Bandel's ring. You have a couple of different diagrams here, but obviously if you were looking at it over here on the right side, you're able to see during this contraction, if we have kind of an issue with this Bandel's ring, then we're not going to be able to have a successful delivery. There's some sort of interruption in those contractions, and we're able to see the physical manifestation of it when we're getting a view of that laboring female. And that fundus is contracting, but the lower uterine segment is not reacting the way that it should. And this here is creating an entrapment, essentially, for this fetus, and fetus cannot escape. So let's talk about effacement. So effacement is the process by which the cervical canal goes from 2 to 3 centimeters in length, again, to a 1 centimeter thick, to a paper thin consistency. Okay, so again, we talked about how the cervix moves up during the effacement and the dilation process. It doesn't actually go anywhere, but it thins during that process as the lower uterine segment stretches out. The mucus plug, which is attempted to be portrayed here, the mucus plug is a protection against ascending infection. The mucus plug is actually very, very interesting. There's nothing here that completely, no bony structure. Remember, these are all soft tissues that are protecting the baby. And when you're looking at a vagina, we never say, oh, you cannot have sex during pregnancy. These women are just no longer susceptible to infection. They're not in, chlamydia and gonorrhea can't possibly infect the baby. That is all not true. We have this mucus plug, and the idea is that it tries to protect the baby naturally by means of this thick jelly substance, making it more difficult for bacteria to travel through, bacteria and viruses. However, it's not a completely foolproof. But we're talking about the effacement process, as this lower uterine segment, as this cervix stretches out and goes up into this lower uterine segment to make room for this head, this mucus plug is actually lost. As it begins to tear away from the cervix, in addition, I don't mean it tears away, but the cervix is actually pulling apart. During this process, it is moving up. You're going to have breaks, tiny, tiny, tiny breaks in capillaries. So you shouldn't have a gush of blood, but in the weeks prior to labor, women may talk about losing days and weeks, might talk about losing portions of this mucus plug that they see just in terms of vaginal discharge, and it can be mixed with either a little bit, and I'm talking tiny bits, of frank or old blood. Okay? When we're talking about the effacement process, the assessment of it is described in terms of percentages. As I mentioned, first-time moms, you're going to have effacement prior to dilation. So this might happen with moms who, like I said, they talk about the mucus plug. In multips, or moms who have been pregnant and gone through the laboring process before, they're going to have effacement and dilation at the same time with that laboring process. So you're not going to see them get quite as excited about a mucus plug because most truthfully, they probably haven't lost the true mucus plug. Those primips might be a little bit more excited. Dilation is the widening process. Okay, so we've got the thinning process, all right, where we go thin, thin, thin here. All right, we've got nothing here, and then dilation is the widening now. All right. So the fully widened open of the cervix, the cervical external os, it initially is closed, remember, tiny here, fingertip, less than 1 centimeter, to a full 10 centimeters. In this particular diagram, they're showing you that the membranes are still intact. That's this little thin white band between the skull of the fetus and what is supposed to be the representation of the cervix. Okay, and you're going to have here some molding. As you can see, that fetal head, we've got some overlapping here. So obviously I'm using pictures, and they're not true to size, but the concept is there. Okay, so we've got kind of, just for your future reference, 1 centimeter is about what you would feel if you put your finger in a Cheerio. It's not the Cheerio, it's the opening of said Cheerio, until we get to the point where we're talking about the whole bagel. Breakfast gets changed. So when we're talking about a contraction as well, we're talking about different parts of a contraction. We have the increment the acme, and the decrement. So the increment is going to be the building up, the acme is going to be the peak, and the decrement is going to be the relaxation. So this is another way of looking at it here. It looks, if you can imagine, it looks similar to a pregnant belly. That was the point of the picture prior to that, okay? So we have a beginning, okay, it's going to get worse, and then we've got the end. So the other things that you need to be aware of on this particular slide include the frequency and the duration.